Hello everyone, welcome to Carousel. I'm your host, Barry Kesselman, and every week we hop on a horse on the carousel and ride around looking for interesting people on interesting subjects with interesting things to say. We have a guest today who's going to fill all those qualifications. As you know, if you've been watching our show, we've had people talk about spy satellites, cancer cells, clowning to help patients at hospitals, books for mothers and families, inventors, people working with small businesses. Even had my daughter talk about how to get into the college of your choice or how to get into a business of your choice. And today, we're going to move into the medical realm. And we have with us a concierge physician and my personal friend and former physician, Dr. Jim Slater. Jim?
Barry?
My pleasure to have you here.
Thanks for having me, Barry. Pleasure to be here.
Jim, let me go through your background a little bit for the sake of our audience. Sure. You have a degree from Tufts,
correct,
which makes you a Red Sox fan. And then you went to New York Medical Center, which should have made you a Yankees fan, but I don't think it took.
Not enough time.
You were a resident at the Mayo Clinic.
Mm-hmm.
You're on the staff of medicine at Norwalk Hospital. You worked in training residents there. Mm-hmm. You worked in the Patient Care Evaluation Committee, and you, for decades, practiced medicine in the New Canaan Medical Group.
Correct.
And then fairly recently, and we'll get into the timing of this, you became what we call a concierge physician and changed the way you do medicine and the business model under which you work. And I'd like to talk about those things today, and I'd like to talk about insurance, which is an inevitable subject in that, and possibly, if you can get to it, your thoughts on ObamaCare. All right? Very good. So let me start off with, why did you choose to leave, shall I call it traditional medicine practice, medical practice, and go into concierge medicine? And then we can talk about just what that is.
Good question. I started practice in 1974 when things were pretty quiet and people had pretty good relationships with their doctors, and you had a reasonable chance of either talking to your physician or getting an appointment within a very short period of time, and you had time once you were in there to discuss what the problem was. Over the decades, starting about 15 years ago or so, the insurance companies came to the realization that, in fact, they held the purse strings to the healthcare industry. And as a result, they became the center of the triangle between the doctor, the patient, and the insurance company. And in my opinion, medicine became a practice where the most important thing was the bottom line for the insurance company rather than the well-being of the patient. And after struggling with this for several years, I felt that I had become merely a pawn in larger governmental and private insurance enterprises that were controlling how I practiced medicine, what medicines I prescribed, what tests I could do, and I felt that I was losing control of the care of my patients to their detriment. And this became quite frustrating. Additionally, as time went on, the insurance companies, in order to enhance their bottom line, kept increasing their restrictions. And by that I meant they limited the number of drugs that were available to patients to those drugs manufactured by those pharmaceutical companies that they had special relationships with. They had the say on whether diagnostic procedures could be performed or not. We had to justify everything that was done. And least of all, they kept reducing the reimbursements to all physicians and providers. This led to the natural consequence of having to see more patients, especially for primary care providers, which I am.
So about, under that system, before you changed over to concierge practice, about how many patients did you have?
Approximately 4,000 patients.
4,000.
Yeah.
And with any group number or single patient that you had, when you worked with them, your primary physician, primary care physician, so people come to you saying, I hurt, this isn't right, that doesn't feel good, what is it? And your primary function is to see what it is, diagnose it, analyze it, and then either send them to a specialist if that's required, and we can get into that in a bit, or handle their medical needs, which would include what tests they might need, what medicines are available for them, what they might need. So you would have, I guess in a forced, very short period of time, you would have to go through the initial procedure.
Right.
How long would it take when you have 4,000 patients to be able to do that? Or how long did it take? And I know this was a frustration for you.
Not that 4,000 patients took a long time, but a fair number of those people needed to be seen every day. And consequently, I would end up seeing 30 or 35 patients every day. And when you're seeing that number of patients every day, the visits are necessarily cut short. And you have to cut right to the chase. And not that that's bad, but there's something lost when you feel like you never really have enough time to go into detail, look up previous test results, and have time to discuss it with the patient and think about it yourself and come to a reasonable conclusion. And it came to the fact that appointments were limited to the now famous 10, 6, or whoever you're quoting, minute appointments. Very, very difficult in primary care, and much more difficult for the elderly people who have multiple problems and are on multiple medications. And it was just, I felt, impossible to do justice to the patient. And I felt very uncomfortable under those conditions.
Do you have any examples that come to mind where you would require something or want something on behalf of your patient, and an insurance company would say no?
I can hardly organize my thoughts on that question, but the short answer is yes. And one particular case that comes to mind is a very elderly woman who unfortunately was becoming demented. And so the usual thing would be to go through the usual rule-outs to make sure you weren't missing some medical condition. And once you've done that, usually to prescribe Aricept, which is a drug that's commonly used for dementia. This quite elderly woman with profound dementia, I then prescribed Aricept for, and for reasons beyond my comprehension, her insurance company denied that request. I've no clue why, but that would be typical of an instance where a drug would be clearly indicated, and an insurance company, for perhaps arbitrary reasons or financial reasons, or just to wear you down so that you don't pursue it any further, would be to say no, and no again. Or you have to speak to another person in the hierarchy of the insurance company. And so it went that it took enormous amounts of time to get what you thought was a simple drug for a simple problem.
And in order to deal with insurance companies as the system evolved over the last 20 years or so, it seems to me that doctors have to increase their staff just so they have the time to do the doctoring. Is that the case?
That is very much the case. When you're seeing that many patients, you need at least one secretary. You need at least one billing person to deal with the insurance forms and claims. You need someone to bring the patient back to the office. You need a staff of 4 or 5 paramedical people to help you deal with the crush of 30 or 35 patients in a day. And believe me, when you're dealing with that number, with other phone calls that come in and other emergencies that arise and other doctor conversations, it's very difficult to do accurately.
I was just made aware of an example of a patient who had blood tests suggested or required by the doctor. The tests were made, all kinds of things were analyzed. The drug company sent a bill to the patient for $435. And the patient sent it back to the insurance company to look at it, and the insurance company looked at it and paid $22 to the lab that did the work. So one question is, and some of the reasons were, these were not authorized, or we don't believe that these were necessary, even though the tests were done. It sounded outrageous.
Yes, I think that's another example of how insurance companies control the rate at which medical care takes place. They're operating strictly on a financial, bottom line, investor-oriented success. The patient is no longer the issue. It's a financial issue for the insurance company to be successful, and that's what's driving largely the healthcare industry at this time.
Now, I know that you're very conscientious, because when you were my physician, and I should tell people that I'm a snowbird, so I'm in Florida a lot, and therefore I have different medical teams or needs or what have you, fortunately very few. But I know you used to call me at 9 o'clock at night to say, Barry, I've just finished up looking at the results of whatever it was, and here it is. So I know you were working until late in the night. And your practice, just so everyone knows, your practice was the New Canaan Medical Group with 5, 6, 7 other physicians?
Was,
yes.
Right.
At the time, I'm sorry,
at the time. Right.
And you became, I know you're very conscientious, and I know this became worrisome that you weren't giving your patients what you thought they deserved. You are, in my opinion, what people used to call a small-town doctor. Caring, devoted, and I really
that was my goal.
And you couldn't do that in the system that has come to be known as the American medical system.
Right.
So what did you do, and how and why did you decide to do it?
Well, first of all, let me say I'm glad you didn't bring up the fact that I kept you an hour waiting to get in to see me before I made that phone call. So thank you for that. Yes, I wanted to stay. We moved here to New Canaan in '74. My kids went through the school, and you get involved with the school system and the kids and the sports program, and you get to know people. And I wanted to stay a community-based physician. I wanted to be available for people of all kinds, and I wanted to do a good job for them. And so I could never get all the paperwork done or phone calls returned, and so often I'd stay at the office till whatever 7 or 8 and then bring paperwork home, and then try to convince my wife that I had some emergency calls to make before dinner was eaten. So yes, I wanted to be a small-time doctor in a small town with a sense of humanity, a sense of commitment to the community, and not lose track of the patient or the town that has been so kind to me.
And so you made, certainly at the time, a giant step that was virtually or practically unprecedented. And what was that?
That's true. In 2005, by 2003, I had just about had it. So in 2005, I made the leap to Concierge. That meant sending a letter to insurance companies and Medicare saying, thanks for your help over these many years, but in 3 months from now, I'm officially opting out of your plans, and you need not send me any more checks. I won't be billing you anymore. And at that moment, my entire life and future and financial wherewithal depended on who showed up. I sent a letter to all my patients. I'm saying, I felt that the healthcare system has become inverted. I feel that you, the patients, have taken the brunt of this, that your health is no longer a prime concern. It's the insurance companies' financial well-being that's a prime concern. I feel this is vastly unfair. I feel the whole thing is turned upside down. And so I'm dropping out, and I'll take a fraction of the number of patients I have and deal with them on a one-to-one basis. Unfortunately, a small practice like that requires a private fee. It's an agreement between a doctor and a patient, where the patient pays the physician privately. To my great surprise, I didn't end up shoveling snow in Vermont. People signed up. It was successful. It's been successful, and since I've done it, one other physician in our group has done it successfully. Several doctors in Westport have done it successfully, and I think more will be doing it in the future.
I want to talk about concierge medicine because it's not one thing, even though many of us believe it was.
Right.
People who see royal pains see this concierge doctor up in the Hamptons who has all these rich clients that call upon him, and he hops into his sob, and he goes around and he handles all their needs at their houses.
Yeah.
They're all very well to do. I don't know if that's what it takes to be a concierge doctor, or if you don't have to have a bunch of really rich people to sign up for you. What's it look like here in this area?
There's 300 million people in these United States, and it's a big market for different kinds of products, just as there is for homes and cars and clothes and cheese and what have you. And there are models that are like that, where there are huge amounts of money charged per patient, $20,000 and up. These people do make house calls frequently. They go with their patients to consultants as their advocate. And it's similar to that TV program. On the other hand, there are doctors who charge as little as $50 a month, and they will do everything basically for $50 a month, and that depends on your market and your location and so on and so forth. And the main thing is to escape the thumb of the insurance companies. Now, you can't do that completely because people need insurance for catastrophic events. And there used to be a good bargain for insurance for catastrophic events, which was much cheaper than conventional HMO insurance. The insurance companies quickly realized that and closed that window, raised the premiums on that kind of insurance policy, and so now it's sort of a wash. There's no real bargain there. So even in my limited practice, people still need insurance. But I have far more time to do battle with the insurance companies than someone who's seeing 30 patients. I have the time to explain why I need a nuclear stress test versus a regular stress test. I have time to explain why I need this drug or that drug. I have time to stand up for the patient and do what I think is right for them.
And when you're doing this to get those services for the patient, you don't get any of that money. That's insurance money is to pay for the services that you believe the patient should have, but it's
Right.
not anything that comes to you on a
That's
business.
correct. It's illegal to be receiving money from insurance companies. Once you opt out of the insurance company, you deal directly with the patient. It's true.
So you opted out or
Mhm.
took this course of advanced concierge medicine because you had just had it with the way you were forced to practice medicine because of requirements from insurance companies, the total number of patients, the inability to really interact and do the kind of medicine that I know you like to do.
Mhm.
From the patient's point of view, the patient has to say that they're unhappy with the same situation that you're unhappy with. And they are, but they still need the insurance because they still need the specialists and the nuclear tests and the x-rays and all of that.
That's right.
So they have to do pretty much whatever they did in the past. But on top of that, layered on top of that, is the patient who says, you know, I want to be sure that my doctor is giving me the best care 24/7. If I need him or her, they'll come to my house.
Mm-hmm.
I know that they're diligent, that they're interested in practicing medicine, and I'm going to pay for that
Mhm.
activity or consulting
Right.
above and beyond everything else.
Right.
Is that the model?
I think you hit it right on the head, really. They still need insurance for catastrophic illnesses. However, the other part is accessibility, availability, reliability, time you spend with the physician, the ability to email non-essential questions, the ability to call and get a live person rather than a phone tree, the ability to get an appointment the same day, the ability to get the appropriate follow-up, the ability to spend satisfactory time with the physician rather than an expected 5 to 10 minute hurry-up visit when half the information is gathered on the walk back to the office and half of it is gathered on the way back to the lab, and so on and so forth. And frankly, I was very uncomfortable with that. I wanted to feel that I had the patient's medical problems well known to me.
Excellent. We have about 5 more minutes left.
Okay.
And I would love to get your opinion on ObamaCare and what you think it's going to do or not do or how it's
Yeah.
going to affect medicine.
That is a difficult question. It's a good question. And the short answer is I really don't know what to make of it. I can give you my opposing opinions. One is we don't know how much this is going to cost. It may cost far more than anybody has projected. Healthcare costs have a tendency to do that. The other issue is that some of the state insurance exchanges that are being set up, which people are required to join, people are joining, but some large providers, hospitals in particular, are not accepting those insurance exchanges, just like perhaps some hospitals don't accept regular conventional insurance contracts. Also, there's the constitutional issue of whether everyone has to pay for health care.
Yeah, well, we can leave that up to
Yeah.
the lawyers.
We can leave that up to the Supreme Court. They've already decided that.
Right.
On the plus side, it is clear to me that the current system is not working. It's just drowning patients in paperwork and increasing restrictions. And it provides for models for healthcare delivery in an experimental fashion that might be used in a larger sense. And most importantly, for the first time, it guarantees that people don't lose their insurance when they go from job to job. A big fare if you've ever had a healthcare problem.
Mm-hmm.
So it's a mixed bag. I think time will tell.
Is there any relationship between it and funding research or funding medicine?
No, I think the monies that are going to be spent will be spent on developing healthcare delivery models to see what's the most cost-efficient healthcare model.
Okay, so back to you and your practice. Are you happy with it? Did you make the right decision?
Absolutely. Every hour of every day is more enjoyable than every hour of every day in my previous life. I feel that I've done a good job. I feel I know the patients, and I hope they feel the same way. And I get my work done. And it's not that I work shorter hours, and it's not a vacation, and it's not retirement. It's the way medical practice, I believe, should be practiced.
Like the old hometown doctor.
Exactly.
And you make house calls.
The way things used to be.
And you have a good retention rate, except for those of us who moved to Florida?
Yes.
Or passed on because
do.
we got to be 130 years old or something.
Yeah. I have a great retention rate. Hardly anybody ever just drops out.
When you see other physicians in conventions or wherever you get together, are they all over you to see what's it like? Is it a good idea? How's it going? With
Always.
An idea of possibly doing the same?
Initially, there was skepticism on their part because it was such a new concept. They didn't know how it was going to go. But since I, a normal physician, could do it, I figure anybody can do it. And so they see an average physician, community-based, enjoying himself and practicing medicine the way they would like to practice. More and more folks are signing on.
Well, it sounds really interesting. I don't know what's going to happen to all of us as we come through this different method of bringing medicine back to what our parents and perhaps grandparents used to think, which was the really good way. It's time for us to say goodbye, so thank you once again for joining us. Dr. Slater, it's always a pleasure.
Barry,
very
always
best. I appreciate
Thanks
you
very much for having me.
My pleasure. We'll be seeing you again, perhaps one last time, because I am doing the snowbird thing to Florida, and we'll be leaving you shortly. Meanwhile, stay healthy, and goodbye.
Well said.